Hello and welcome to our reproductive life planning case presentation. This case study was done by Marta Bebeck, Lisa Warrior, and myself, Kate McMeekin. The case we were given is on patient Marie, who is a 23-year-old college student. She is here today for her annual exam. Marie is a G0, P0 and has not had a previous PAP test. She is sexually active with 2 partners and occasionally uses condoms. She would like information on birth control, and she has told us that a friend of hers is on a pill that has different colors in the pack, and she's wanting to try the same pill. Because Marie is young and may not be seeing a primary care provider regularly, we are going to go a bit more in depth in her past medical history, review of systems, and a physical assessment. We feel that by gathering more in-depth information, we will have a better baseline for future visits. After introducing ourselves to Marie, we start to collect subjective data, including allergies, past medical history and infections, hospitalizations, surgeries, immunizations, medications, and medications she may currently be taking. Specifically for her gynecologic visit, we want to know how old she was when she started her period, when she had her last period. We ask if her cycles are typically regular or irregular, heavy or light in flow, and how long it usually lasts. We also want to know about her premenstrual symptoms. We know she has not had a previous PAP test, but has she ever had a recent physical exam? Marie's family history is important to us as it will allow us to know what she may be at risk for, including reproductive cancers, breast cancers, bleeding disorders, and stroke. Knowing her social history helps us to better gauge her life and lifestyle. We know she's in college, but is she working? Who does she live with? Does she use tobacco? As we know, the use of tobacco when on specific birth control pills can increase the risk for DVTs. We know that she is sexually active and has 2 partners. Are these both current or at different times in the last 12 months? Are her partners male, female, or both? What kind of sexual contact is she having? Genital, anal, oral? When was the last time she had intercourse and was it protected? She states that she uses condoms on occasion. What occasions is she finding it difficult to use the condoms? We asked if she has a history of STDs or if any of her partners have ever been treated for an STD. What does she know about STDs and their transmission? Does she need more education? We also asked if she's wanting to get pregnant in the near future. We asked general questions about her overall health, including her skin, hair, nails, head and neck, cardiovascular, respiratory, musculoskeletal, neuro, and psych. We asked about breast tenderness, changes or lumps, as well as abdominal pain, nausea, and bloating. Finally, urinary symptoms and gynecologic complaints, including pain and discharge. We discussed with Marie that every female is different and that there are a variety of options that may better fit her lifestyle. We believe that a long-acting reversible contraceptive, specifically an IUD, would be the best option for her as it is shown to be the most effective in pregnancy prevention. She would not have to take a pill daily and still be protected against pregnancy. She would still need to use a barrier, such as a condom, to protect herself from STDs. We explained to her that Skyla IUD is very small and would be inserted into her uterus, where it will remain until it's time to be replaced in 3 years. It could also be removed earlier should she decide she wants to get pregnant. We asked how she would feel about having a foreign body in her uterus and if she felt comfortable feeling her genitals to verify the strings of the IUD. We also discussed Nexplanon, which we explained would be implanted into her arm and similarly have the similar effects and need to be replaced at 3 years. We explained that LARCs are safe for women of her age with no prior history of pregnancy. Pending a negative pregnancy test and no history of intercourse in the last 2 weeks, we could start a LARC of her choice today. We explained that because Nexplanon would be inserted in her arm, it would not require a pelvic exam prior to insertion. However, because this is her first time and she is sexually active and over 21, a pelvic exam and STD and HPV testing would still be recommended. We clarified that birth control pills are still an option, but they have not been found to be as effective as LARC. The following slides assume that Marie decides to go ahead with the Skyla IUD. Objective data obtained on Marie's visit include her vital signs, height, and weight. We ran a urine pregnancy test, which for the sake of this case is negative. We did a general inspection and determined that she is a good historian, pleasant, and appropriate. We inspected her skin and nails, looked in her mouth, checked her thyroid. We did a quick listen to her heart and lungs. We performed a breast exam, noting any tenderness, lumps, firmness, and pigment changes. We palpated her belly, assessing for pain, tenderness, masses, or distension. ACOG states that after the age 21, a pelvic exam is recommended annually, but evidence neither supports or refutes it for an asymptomatic low-risk patient. They also state that a bimanual exam prior to procedures such as inserting an IUD is indicated. Because our patient is sexually active with multiple partners, we felt that a speculum exam, as well as testing for STDs and cervical cytology, is warranted. We performed an external exam, a speculum exam, collected our specimens for lab, and performed a bimanual exam as indicated. Our assessment for Marie's encounter would be an encounter for gynecologic exam without abnormal findings. This ICD-10 code encompasses the well women annual exam visit she is here for today, along with the normal screenings that may go along with her visit, such as cervical cancer screening and STD testing. The other differentials that we would include in this visit are encounter for initial prescription of intrauterine contraception device, encounter for other general counseling and advice on contraception, and counseling for other STDs. We have taken samples for the cervical cancer screening as well as chlamydia and gonorrhea, which are pending results. Should there be abnormal cells found on cytology, we would order reflex HPV testing. Should she be positive for chlamydia or gonorrhea, we would prescribe recommended antibiotics. For this case, we assumed that all STDs were negative. The decision was made by Marie to insert the Skyla IUD during today's visit. Patient education is the most important in this particular visit. Marie was educated on various options available for contraception. We discussed the importance of cytology and HPV testing and the need for her to repeat the testing again in 3 years. Additionally, education was provided on STDs and the correct use and consistent use of condoms. Marie is aware that side effects of Skyla, including menstrual irregularities. She understands that it will need to be replaced after 3 years, and it will no longer be effective against pregnancy after that. She was informed to use additional non-hormonal contraception, such as a condom, for the first 7 days after insertion. Marie was instructed to make a follow-up appointment for IUD placement, to check IUD placement 1 month from now. We instructed her to personally check the IUD strings frequently and make an appointment if she cannot feel them. We instructed her to call the clinic should she have signs and symptoms of pelvic inflammatory disease, including abdominal pain, fever, and foul-smelling discharge. Finally, she was instructed to go to the emergency room if she feels severe pain in her lower abdomen, as it may be an ectopic pregnancy, which is a medical emergency. This is the prescription that was written for Marie. It was available in our office today. The prescription was written for 13.5 levonorgestrel releasing IUD with no refills. It also specifically states for only the provider to open the package, as it contains both the IUD and the insertion kit. The IUD works by preventing the sperm from fertilizing the ova. It does this by creating a hostile environment that is toxic to sperm and the ova, impairing the sperm survival and motility, increasing sperm phagocytosis, thickening the cervical mucus, suppressing the endometrium, and impairing the ovulation. Multiple contraindications associated with the IUD are as followed: pregnancy, PID, cervical and endometrial cancer treatments, and undiagnosed vaginal bleeding. Gestational trophoblastic neoplasia, if they already have an IUD, it does not have to be removed, but we cannot place a new IUD. Fibroids that do not disrupt uterine shape are also okay for placement. The American College of Nurse Midwives and the CDC and ACOG all agree that IUDs can be used by women of all ages, paris and null paris. IUDs should be offered routinely because they are safe, effective, and because of the safety, the effectiveness, and the ease of use. Furthermore, IUDs are found to be more effective than birth control pills, birth control patch, and a vaginal ring. There are multiple studies that agree that IUDs are very effective, safe, and tolerated well by women. They are an excellent choice for contraception for all women. Studies report that high satisfaction and continuation rates among users. Multiple different types of IUDs are available to accommodate different needs, such as hormonal versus non-hormonal, and multiple sizes for the ease of insertion process in null pairs women. Thank you so much for listening to our case study. We hope you learned as much as we did. Thank you.